They can be going nuts where they're scratching. And again, it's those funny areas, elbows, knees, buttocks, and they're so uncomfortable. They can't really seem to get to the itch. I find it's even more intense and deeper in general than atopic dermatitis. And those patients are miserable too. They're among the worst in prurigo patients, but this maybe the ones I've seen are among the highest itch. And it's just so intense and so localized, they're going crazy.
Dr. Leo, I am so not only excited and honored to have you back on the show, but you and I are going to talk about a topic that has never in 5 years, I think, of the entire show ever been discussed, which is dermatitis herpetiformis. And I thought of you because I got so many requests about this because you have such a great way of breaking down some of these conditions that are lesser known or are more complex. So tell us, what is dermatitis herpetiformis?
So it is an interesting condition. First, thanks for having me back. It's always so fun to be with you and talk about this. And this is a really important subject because it is truly at the interface of skin and gut and diet, right? I mean, it's right in our wheelhouse, which is so fun. So dermatitis herpetiformis, or DH, is really an inflammatory autoimmune disease that actually results in tiny blisters. Although most patients, when they see it, they tend to look more eczematous. In fact, it can be one of the things that can masquerade or trick us that it's actually eczema because they tend to scratch at them when they're tiny. So you don't often see them as true blisters, but just more open sores and kind of irritated skin. It's incredibly itchy. And what's remarkable about it is that it is fairly rare, but it's an important signpost in thinking about the differential possibilities for some of the things going on in our skin. It is really the visible manifestation, the skin manifestation of celiac disease. And we know celiac is this condition where you make a particular kind of antibody, IgA antibody, to gluten, and specifically the part of gluten called gliadin. And this also cross-reacts with our skin. So we can actually see when patients are eating gluten, then they can develop this rash. And what's remarkable is when they stop, if they're really good, it disappears. So it is sort of the archetype of the dream of what if diet were driving my skin problem, and could I take this out of my diet to get better? And the answer here is yes, almost 100% yes. It's really perfectly connected, as opposed to so many of the other things we talk about where diet has an important influence and can play different roles, but often gets sort of thrown in there and people keep looking for stuff in the diet even when there's nothing there. This is one of those cases where it is the whole story.
So for someone who, let's just say, they notice they have these rashes, come across information on the internet, and they go, maybe I should go gluten-free. They take gluten out for, I don't know, even let's just say 2 weeks, 30 days, and they notice an improvement. Would that be important for them to tell you as the dermatologist if they go to see you and they're showing you their skin? Is that helpful for you to know?
It's definitely helpful. The biggest thing we have to differentiate it from is eczema, and that, in my experience, or allergic contact dermatitis as well, if they're allergic to something in their environment. And of course, we know that the world is never as clean as in the textbook. Sometimes people have multiple things. I have patients who really have allergic contact dermatitis and dermatitis herpetiformis, and you're saying, wait, why are you not getting fully better? And so we have to do a couple things to figure it all out and unravel it. But you're absolutely right. If they cut a food and they find that it makes it, and really here it should be dramatically better. It should be essentially clear. Now, the one caveat, and you know this better than anybody, is that gluten is hidden in all sorts of foods. So sometimes people say, well, I stopped eating bread and it got better. And it's there's a lot of gluten you're still exposed to. So that might not be enough. But if you're truly doing a gluten-free diet, and you get better, that would be important. The way that we diagnose it, though, almost always is going to be a skin biopsy. We're going to take a piece of skin, we actually do a stain, and we can see the IgA antibodies lined up. You can actually see them in the skin. I mean, it's really, really beautiful and clear. It's fluorescent, so you can actually, if you look online, you can see some beautiful pictures of the beautiful clumps of IgA that are binding to those proteins, and you can see what's happening, we think, is that it damages it so that the skin can't hold on, and it opens up, and fluid fills in. That's what's happening with an autoimmune blistering disease. The skin starts to literally fall apart, fluid collects, you get a blister, and then it opens up and becomes a sore.
Oh, wow. And is the staining of a biopsy, is that like a routine part of a biopsy, or is that something that the dermatologist has to ask for?
Great point, because absolutely, if you just do a regular old biopsy for we call it an H&E stain, the traditional staining that we do, that will not show this. They actually have to do specific immunofluorescence. So they have to go in thinking, and I actually have to put it in a special medium. If you put it in formaldehyde, it often will not work correctly. So we put it in like a saline type or a special medium called Michelle's medium. And we send that, and then we tell them we need immunofluorescence with our concern of an autoimmune blistering disease, including Dermatitis Herpetiformis. So then they can tell us right away. Now, if we didn't do that, they still might get an idea from the regular H&E stain. They might say, this is suspicious for it. But other things that help us are the distribution on the body. It loves elbows, knees, and buttocks. The butt is itchy. And that's a little different than eczema, right? The eczema is usually the other sides. It's more the flexural areas, although again, it can be a little confusing at times. And sometimes if I look, especially with my little scope, I can see tiny blisters there. And I'll say, this looks more blistery rather than pure eczema, even though, again, clinically, just looking in the room, it might just look kind of open and scratched and irritated.
Now, if you were to, say, run this special type of biopsy staining, do you think it's also helpful to run like a celiac blood panel as well as genetic testing? Is that something that a dermatologist would do, or would you refer them back to like a primary care doctor or gastroenterologist to have that done?
Typically, I'll do the celiac disease panel, which is, a bunch of antibodies on the blood. I usually don't do genetics because usually if they have the IgA in their blood, that will also lock down the diagnosis, and it is good to know. While we often see patients with both GI issues and the skin issues, it's absolutely true that some of the patients truly just have skin issues. Their gut seems to be okay, and we verify this by having them get scoped to make sure there's not some early changes in the gut, but some of them truly just have skin. And I think the majority of patients with celiac disease only have the gut and don't have the skin. So it's not a very reliable indicator, and we don't fully understand why we see it in some people and not in others.
This episode is brought to you by my skincare line, DermaQuell. The beauty of these skincare products are that they are especially crafted for those struggling with chronic skin rash issues based on my research and clinical experience from my private practice. They focus on organic ingredients that are clean like zinc, aloe, and hemp oil that support and calm rashed, dry, angry skin. There's no unnecessary chemicals or additives that can further dry out your skin or mess with your hormones. And I'm so excited for you to add these creams into your routine. Check them out at quellshop.com and use the coupon code GET15OFF to get 15% off your first order. I'll put a link in the description below, and now let's jump back to the video.
And I was going to mention that as I was reading different papers to talk to you today, I read this quote, which I'll put in the references below this episode, that less than 20% of people with DH have symptoms of celiac disease. So my assumption was that this person must have all of these GI complaints or some sort of reaction to gluten that's pretty obvious. Like you said, you eat a piece of bread or you have a bowl of pasta and you feel horrible afterwards. But that's not necessarily the case. So like you said, if you are having some sort of reaction, maybe that could be helpful to tell the dermatologist, but you might not actually have that reaction of like, wow, something gastrointestinally is wrong here. And I think that's important for folks to realize. And another thing I wanted to just ask you about is, I've also read that dentists, and I've interviewed a number of dentists on the show because I find the oral microbiome fascinating. And I talked with a dentist earlier last year who discussed that they can find signs of nutrient deficiencies in the mouth, but it sounds like DH could possibly have some oral microbiome, oral signs like erosions impacting the mucosa in the tongue, maybe pain or a burning sensation. So if someone is also experiencing that, I find a lot of times people may go to a derm and say, like, I have a rash. And they don't give other potential clues that could be helpful to you. Like you said, it could look like eczema. So do you find that like maybe it's a good idea, like if your dentist is also saying, hey, I'm seeing some weird changes here, and you're having this type of presentation, that could be helpful for a dermatologist to know?
Absolutely. And, I try to ask those questions and be perceptive, but there's no doubt sometimes you're kind of in your zone. You're like, oh, I think it's just eczema. You're not even asking the key questions. You're not looking in the mouth all the time, which we really should. So you're right. Things like aphthous ulcers, the canker sores, angular cheilitis, the lips can be very inflamed, cracked, fissured. They can be chronic and difficult to treat. One of the things that's confusing too is that there may be some specific connections with the celiac or with the IgA antibody. Some of it might be, as you said, secondary to low vitamins and minerals, because you actually have an absorption process in your gut. So now we have a couple of things that can compound, and that's maybe partially what's explaining the angular cheilitis. If you get deficient in certain vitamins, you may have that or maybe more prone to it. So that's important. Dry skin, some nail and hair changes are also sometimes visible. And then specifically with the teeth, they can have thin enamel on their teeth. So there can be specific findings.
Oh, well, this is just perfect. Because like I said, it's helpful for someone to know what they should tell their dentist or their dermatologist or their doctor to try to get the appropriate diagnosis. I always think it's helpful when you can bring the right set of information. That's always helpful. And then I also noticed that there tends, because this is an autoimmune disease, usually the stats are once you're diagnosed with one autoimmune disease, it makes you more at risk to be diagnosed with more autoimmune diseases, unfortunately. So you're like at greater risk for a second, for a third, which is unfortunate, but that tends to be the case, especially with women. So are there other conditions that you find or have seen in your practice where someone might be diagnosed with DH and then they also have something else going on prior or before getting this diagnosis, or maybe they develop something afterwards?
Yes, I think, one of the hardest parts for us is that there are sometimes a personal or family history of other autoimmune diseases. So thyroid's the big one that I've seen, and it's really worth checking the thyroid function. Pernicious anemia, the vitamin B12 binding issue, type 1 diabetes, vitiligo, things like that. So we can see these associations, which makes it a little tricky. The other big piece that's really important, I think, for everybody thinking about this to know about is that if you have this condition, celiac, and you don't cut gluten, you actually do have a much higher risk, something like 5 or 10 times the risk of getting a non-Hodgkin's lymphoma. And that's actually really strange. We don't fully understand why. We think it's kind of a chronic immuno overstimulation. So I've had patients sometimes who say, well, I don't care, you're going to treat my skin, I'm going to keep eating gluten, which we have to talk about this because this is one of the most fascinating psychological pieces of this whole puzzle. But I'll say, listen, actually, it's not just about your skin. Maybe with medicine, I can get your skin better or comfortable enough, but you still have the risk as long as you're eating it. And that can even happen in your gut. You can have a lymphoma in your gut, which is really scary.
Wow. I had no idea. That is really scary. My goodness.
The psychology of it, though, is what's so fascinating to me. And again, this is a pretty rare condition. So I think in this day and age, many people point to gluten early on, right? Gluten and dairy are kind of the two villains. And I love you talk so beautifully about it in so many of your episodes where you put it in perspective. And I do think, they can be inflammatory. Some people truly have allergies. Some people really do have celiac or dermatitis herpetiformis. They might have lactose intolerance. There are many reasons why to avoid those, of course. But I sometimes think they're just vilified unnecessarily by some people. The remarkable thing, though, is so many of my eczema patients really would love to have a single food or foods to avoid, right? Sometimes they won't let go. I'm like, I know, I wish we had something. I don't know what to tell you. You've seen experts, and I think we just have to treat you. I wish I could find the root cause, but we're often not able to yet. I mean, hopefully one day we're going to be able to figure it out perfectly, but a lot of times we can't. So they're frustrated that I can't find something. The opposite effect is true here with these patients. And again, it's fairly rare. I only have a handful in my whole panel, but when I make the diagnosis, I'm usually excited. I'm over the moon. I'm like, the test was positive. We know what this is. This is unbelievable. We can just cut gluten. And now the world is so friendly to gluten-free people. You can go anywhere and get it. In the 70s and 80s, it was brutal. You really didn't know what you were up against. But now, because it's so widespread, it's cheaper and easier. And you know what happens? Honest to goodness, they cry. Many patients start crying. And I say, wait, what's the problem? They go, I don't want this. I want to eat bread. I want to eat cookies. I want to eat cake. I don't want to have to deal with this. And I'm like, but we know the root cause of your disease. We can fix it just one type of food. And you can have gluten-free muffins and cookies and cakes. They're crying. They're so devastated. And they're saying, is this forever? What medicines can you give me? What drugs can you give me? And I'm like, I feel like I'm in a bizarro world. I have most of my life, which is patients begging me not to use drugs and find some other way around this. They'll do anything. They'll move to the moon and go in a bubble for eczema. And then I have a group of patients where I have the answer. I'm handing it to them on a silver platter, and they don't want it. It's just the most remarkable, mind-bending thing.
It is hard. I mean, I will say, because both of us, well, we're both Italian, and I will admit that when I found out that gluten was a problem, I think on one hand, I was relieved because I was so sick all the time. But on the other hand, and like you said, to your point about perspective, a lot has changed because I had to remove gluten in 2008. So the alternatives were awful. They were so bad and there wasn't many options. It was so hard. Now there's so many options. There's so many alternatives. There's products everywhere. You can order lots of things on the internet. You can go to restaurants. There's so many more options. Now, granted, is it perfect? No, but there's so much more opportunity to live a much more normal life. But I can understand there is a grieving process with having to break up with gluten because I don't miss it so much anymore, but there are moments like when we're in Italy and I'm just like, oh, I would love to try that homemade tagliatelle. And it's like, no, gotta go for the gluten-free version.
And it's a great point. I don't mean to sound insensitive because it stinks to have any condition like this and it's no fun. And of course the world is filled with all these things that have gluten anyway. So it is hard. So I never mean to minimize it, but only that it's so exciting to actually have an answer and they don't want that answer. And I get it, but it's just crazy. I wish, the two groups of patients, I think the eczema patients would sell their soul to have that as the answer. They do it anyways. As you know, many eczema patients cut gluten and dairy just trying. And the classic response we hear from them is it's a little better when I do this, right? And it's like, it's probably not the whole thing. But you got to do it, whatever it takes to get you there. They would just love for that to be the whole story.
Yeah. And I do want to just be very clear. This is gluten-free at a celiac level for life. This is not like we go gluten-free for 2 years and then try and reintroduce it and see how we do. And I would also just, as a clinical nutritionist, caution people against sourdough bread because I realize it's fermented and it's supposed to help break down the gluten, but there's truly no good proof that it's completely gone. And this is an autoimmune disease. So I think it's worthwhile to mention, just in your experience, if someone is like, okay, cool, I'm going to take gluten out for dermatitis herpetiformis, like approximately how long do you have to be gluten-free to really see the skin clear up?
In my experience, it's actually pretty fast so long as they're strict. And I love the way you pointed it out. It's different than just kind of, comfortably gluten-free and trying to avoid gluten or something like that. This really is being pretty crazy, reading labels, making sure, because even things like soy sauce and all sorts of different soups, they have gluten in there. So you have to be pretty intense. But in my experience, honestly, just a few weeks, at the most a month or two. In fact, if somebody came back at a month or two and said, it's not much better, it's only a little better, I'd say, we really need, you're missing something. And then I would, if they haven't already, I would refer them to somebody who has a lot of experience because I would expect it to happen pretty quickly.
And just out of curiosity, because I think it's worthwhile to mention just because this is an autoimmune disease and my own experience being involved with a celiac organization many years ago, if they are positive for DH, thus celiac, essentially, do you also recommend that relatives get checked for celiac? Because my understanding is there's a greater risk.
I think that's a good point. I think you're probably right. And there definitely is a family connection. Usually I haven't, but maybe I should. I usually just talk to the patient. I do make sure they see a gastroenterologist, even if they don't have any symptoms, because I want to make sure that they're being screened. It's possible later they would develop GI symptoms. So I want to make sure they're following up, at least having a consult visit with somebody. And hopefully they'll tell them if they feel like they should have family members do it. But I'm not sure on that. So that'd be something I'd love to look into and we can get back to the listeners.
Well, so also too, like if someone's in an acute situation, right? So they've got open wounds, like their skin is really angry and upset. That's great to go, well, it could take a few weeks, go gluten-free. Is there anything else to bring someone relief from the horrible itching? Is there anything else in your toolbox that you might prescribe in the meantime while they're getting gluten out of their life?
Absolutely. And the truth is, nothing is great compared to taking the gluten out because that's really what's driving this whole process. But sometimes people are miserable. Our treatment of choice is the oral medicine called dapsone, which is kind of an old-fashioned antibiotic that really, we don't use it for many bacterial infections. It's almost always used for this kind of inflammation pattern. And it usually works within just a few days. Many people can really clear up. And that's why it's so tricky because people, when they're feeling better on it, they'll say, oh, I can still have gluten, right? And I say, well, this is this funny lymphoma thing. We don't understand it. What's also remarkable about Dapsone is that there is a topical version of it too. It's used for acne. And so sometimes I'll give people both. I'll say you can take the pill and you can put to these trouble spots the topical. We don't necessarily know if that is really helping, and it is technically off label, but I do have samples of it. Sometimes I'll give people that. Sometimes we'll also use topical steroids to help, and even like strong antihistamines can kind of help you sleep at night, to kind of knock you out a little bit. But the real secret, I think, is really getting them on the Dapsone and avoiding the gluten.
So what I'm hearing from you then is that the itching is fairly intense with this.
It can be absolutely crazy. They can be going nuts where they're scratching. And again, it's those funny areas, elbows, knees, buttocks, and they're so uncomfortable. They can't really seem to get to the itch. I find it's even more intense and deeper in general than atopic dermatitis. And those patients are miserable too. They're among the worst in prurigo patients, but this maybe the ones I've seen are among the highest itch, and it's just so intense and so localized. They're going crazy.
Okay, that's good for people to know too, because I know with other episodes when we've acknowledged the severity of certain symptoms, especially itchiness, because I had that lovely opportunity to be in your office and watch you work with patients. The one thing that I deeply appreciated was the fact that you could acknowledge what they were going through. You didn't dismiss their daily experience or the pain or discomfort. And I think it's really helpful. And I know a lot of listeners of the show have deeply appreciated when guests acknowledge how bad some of these symptoms and debilitating some of them can be. So I appreciate you for that. And I wanted to mention one quick thing, because I realized as we were talking and you made a really good point about how with celiac disease, some of the signs are anemia. So you can have iron deficiency anemia. You can also have megaloblastic anemia, which is a little sometimes tricky to figure out because you have to look at B12, you have to look at vitamin B12, vitamin B6, and folate. And sometimes you can have multiples that are low or one is really off. Sometimes folate deficiency or B12 deficiency can mask the other. So those are important to know. And I would just say, as a clinical nutritionist, if you do end up with this diagnosis, to make sure that somebody, whether it's a gastroenterologist or your PCP or somebody, is looking at those markers just to make sure. And vitamin D can also be low in celiac disease as well. So it's always important to get those levels checked to make sure that you're supplementing appropriately and you're handling your diet appropriately. So my last question, because I really sat with this condition and I'm oftentimes asked, well, if I'm going to go gluten-free, do I need to make sure my skincare is gluten-free? And so normally the answer is no, because the reaction with gluten sensitivity and celiac disease is in the GI tract. But then I thought about this. You're actually having an autoimmune reaction at the skin. Granted, it doesn't originate there, but I figured you'd be the best person to ask, since oats are oftentimes used in products. They may not be gluten-free oats, which is a whole other thing to know too. If you get this diagnosis, you got to be really careful with oats because they tend to be contaminated due to processing. So if someone is diagnosed with DH, do they have to worry about skin contact with gluten in products or just in general?
I think it's a really important question, and I don't know if there is general consensus in dermatology community, but I'll tell you my approach. I actually do think you're right, because we know the tiniest trace amounts of gluten can trigger this reaction, and because, again, the stakes are, itch is terrible and the rash is terrible, but even beyond that, this weird looming thing of lymphoma, which makes me a little nervous. So yes, I do tell people I'd like you to use gluten-free products, and fortunately, again, many products now have a gluten-free, they've been certified, and even if they use oatmeal, they'll say this is certified gluten-free oatmeal, which is great. So as best they can. Now, in a pinch, if somebody had a product they weren't sure of, or we're going to use some kind of a makeup, I suppose it's not too worrisome, and it's unlikely they're going to have a terrible reaction from a small exposure to something, especially that's maybe co-processed or unknown. But I do think we should do everything in our power, because something like a lymphoma would be pretty intense, and I don't want anyone to go through that unnecessarily.
Yeah. And I would also say, especially what you put on your lips, whether it's some sort of balm or lipstick, because they do put gluten and other things in. We ingest a lot of what we put on our lips. So you do definitely have to be careful. And fortunately, there's a lot of There's several celiac websites, different organizations in the United States that you can go to, and I can put some of those in the resources for this episode to help anybody who may be looking for some guidance around how to, because you have to essentially, like, it's essentially celiac disease. So you have to treat it as such, even though there may not be, hopefully, a GI component. Hopefully, fingers crossed, right? That's the goal. Any final thoughts, Dr. Leo, for those who are diagnosed with this or are thinking like, wow, this sounds like me?
Definitely see a dermatologist, tell them what you're thinking about. And it's fairly easy to diagnose. It's just often forgotten. In fact, I'll never forget as I think a first year, maybe a second year medical student when we were still in class, they told the story of a patient that had seen, 8 or 9 different specialists and nobody could figure it out. And then finally the dermatologist biopsied and made the diagnosis. And this was a while ago, now more than 20 years ago. And it was still considered a really rare condition. Very, very little was known about it, but that stuck with me for all the years, remembering, just the kind of zebra cases where you're thinking, boy, no one can figure me out. Nothing's getting me better. And I've internalized that. When I inherit patients who have eczema or a rash that I don't understand, we really try to do a pretty full workup. We're going to do a biopsy. We're going to do blood work. We're really trying to find out if there is something because, again, while the patients aren't always happy to hear it, it's good to know what something is. It's good to at least be able to define it and have parameters. Sometimes I think the hardest thing is not knowing and not being sure. I had a patient where we were talking about the alpha-gal allergy from tick bite where they're allergic to meat. This whole thing, it was fascinating. And just a few years ago, we didn't even know about this. So we're always learning. Medicine keeps moving forward, and that's why we can't give up. I don't want people to lose faith or hope. We have to keep trying, keep getting new ideas, because eventually we can help a lot of the patients. And this is a great example, even though it's not always pleasant. What a win to be able to cut something out of your diet and be totally symptom-free.
Yeah. Well, thank you so much for sharing your experience and expertise with us once again. And you do see patients in the Chicago area. So I know that you always have people flying in from all different places to come see you, but it was such a pleasure to watch you in action. I've seen you at conventions, meeting with patients, talking with other doctors and practitioners. I just love you always are so present and so giving, and I just love that about you. There's like such an open-mindedness. I know your patients, the thing that resonated with me most was how deeply appreciative they were for how you listened to them. And that's why I know everyone in this audience loves hearing from you. So thank you so much for sharing this information with us.
My pleasure, and thank you for the kind words. We'll do this again soon sometime, I hope.
Absolutely. If you enjoyed this video, you need to tune in to this video next. Then make sure to hit the subscribe button so you get notified as soon as a new episode drops. I'm excited to see you there and dive deeper with you on your skin healing journey.